Thank you both for being here, and I will hand it over to Aideen.
Hi there. My name's Aideen Fogel. I'm here today as a caregiver. I also work at CAMH. I work at the Azrieli Adult Neurodevelopmental Center. And I'm here really as a parent to a 28-year-old who is autistic, IDD, multiple complex needs, and as a psychiatric service user. And I speak to you with his permission, absolutely. And one of the things, looking at today's topic, it's so important for caregivers, and that's why I want to frame it before we bring in our expert speakers, from the caregiver lens. And when my son was first prescribed antipsychotics, I had no idea. I really didn't know what to expect. I thought, maybe give it a couple of weeks and things will stabilize. And it didn't quite work like that. We had 2 years of trials. We had lots of different side effects and medications, subsequent medications to deal with the side effects. And it's almost if I could have known then what I know now, I thought this was, this is such an important topic for caregivers. And with that lens, looking at this topic, unpacking it, coming up with any questions that you have that our experts might be able to answer, I'd love to hand over now to Yona Lunsky.
Thanks so much, everyone, for sort of introducing today. It's a fireside chat. I don't know, Mahavir, if you've got your marshmallow and hot cocoa. I've got mine right here.
I got a cable-lit sweater to set the mood, but no warm drinks.
You got the sweater.
I'm not a pro, I learn. Yeah.
Okay. So yeah, this is an important topic. Thank you, Aideen, for sort of situating it, I think. When you're in that situation, right, where you're the family caregiver, or if you're being prescribed these medications yourself, like sometimes there's only so many things you get to ask in that appointment, that initial appointment, right? And there's all this processing that happens after, and we can all do things like go online and look stuff up, but we thought it'd be really valuable to just have a bit of space to sort of discuss some of the issues that people have asked about sort of time and time again, and have a bit more time to learn from an expert. So I'm here kind of offering the developmental disability lens side of things. And I've studied antipsychotics in the sense that I've studied how they're used and what people experience sometimes when they're using them. But I don't prescribe them, and I don't really understand how they work. And that's the beauty of me being able to chat with my colleague, Mahavir, who I'll introduce in a moment. But just to sort of frame why this seemed like a really important medication to talk about, my team at HCARD has been involved in research looking at not just what's happening in our clinic, say at our hospital, but looking across our province. And we were able to look at a group of about 50,000 adults with developmental disabilities, kind of following them over about a 6-year period. And we found that 39% of those adults were prescribed at least one antipsychotic medication. So it's the most commonly prescribed psychotropic medication in our population. And in fact, the rates are even higher if we look at people who are living in group homes. So in the study that I'm talking about, and I'll post a link after, over half of the people living in group homes had been prescribed at least one of these antipsychotics. And they have a number of side effects. Sometimes they're really beneficial and they can really help, and we'll learn about that. But sometimes people don't know a whole lot about how they work or why they're taking them or how to manage those side effects. They're not really sure they can ask those questions. And I think that's kind of why we wanted to talk about that today. So my colleague here, Mahavir Agarwal, is an expert in the area of antipsychotics and has been studying them for a long time. So I'm going to kind of just throw questions at you, if that's okay, and you can always throw them back at me. And then we'll also see what other questions come up in the chat, as well as some of the questions that we've already seen, which I'm using to shape my questions. So Mahavir, are you ready?
Yes, I am, Yona. Thank you.
So,
I'll try my best to bring my expert hat to this.
Okay. So the first big question is I'm kind of curious, what got you to even study antipsychotics in the first place? Why this area of research? So many things we could study.
Thank you, Yona. I was not prepared for that one. I've always been interested in psychiatry, largely because while I always wanted to be a physician, I also wanted to add to the body of medicine, not just practice it. And psychiatry seemed like an area where there's just infinite unknowns. The brain seems to be the last frontier, and psychiatry appeared to me as the most sophisticated way of appreciating it. And so that got me into psychiatry. And then after I came into psychiatry, I got interested in psychosis because they seemed just so fantastical. And to know that some of us can experience these symptoms and believe them to be true got me really thinking about how the brain can work. And related to that, antipsychotics became a focus because that's how you treat some of these disorders. And then I quickly realized that antipsychotics are used way beyond psychosis. They are among the most diversely used medications we have in our group of medications in psychiatry. And so that got me interested into looking at antipsychotics and their effects and side effects. And there are just so many of them, and there's such a huge diversity that there's a lot to study and a lot to understand. And I think in my lifetime, I will not exhaust all the questions that there are to know and learn about antipsychotics. So it's a very interesting field. I also feel that it's an impactful field because most people who are started on antipsychotics are not doing well. And it's my ambition to make sure that that experience of being on antipsychotics, difficult as it is not more difficult because of the side effects. And so it's my ambition to ensure that antipsychotics bring all the good that they can bring, and we minimize the side effects. And that's been lately the bulk of the focus of my work.
All right. Wow. Yeah. Very good unpacking there. So we'll get to the side effects piece soon, because I know that's where some of your research has gone. And that's a big thing I think that people with disabilities on these medications and families are, really concerned about. But you talked about how, you were interested in these medications for psychosis, but that actually they're used for so many different things. Sometimes we hear the word kind of off label, right? And people don't really like. For the people I was talking about with developmental disabilities, some of them are receiving these medications because they also have psychosis, because this is something that you can have with or without a developmental disability, some not. But can you talk a bit about what it means when a medication is prescribed off-label? Like if someone gets that medication, but they haven't been told they have a psychosis diagnosis, is it bad that they're being prescribed that medication? Why do we call it off-label? What do we do with that?
Right. That's a great question, Yona. The off-label designation by itself does not lend, I don't think that's either good or bad. It depends on the context. So let's go back to what label is or what on-label is. On-label essentially means that a drug company developed a drug and then it wrote to regulatory agencies such as Health Canada in Canada or FDA in the US and said, well, look, I have this drug and we have data to show that this drug works for this particular disorder. And so the regulatory agency goes back, looks at all the data and says, okay, yes, you have shown that this drug works for this particular indication. And so we will give you an indication for use in this particular disorder. So a lot of antipsychotics, for example, will try and obtain indications for psychosis. Now, let's take the example of another drug, an old drug, for example, aspirin. When aspirin was first developed, they sought indication for, let's say, pain relief, right? Now, aspirin is 80, 100 years old, however much long time it has been around us. Now, aspirin is a very cheap molecule. Now, that does not mean that people are not researching aspirin. People are still looking into aspirin because there's so much still to find about human body. Let's say tomorrow they find that aspirin, I don't know, makes your hair stronger, right? But then there is no drug companies, the drug company's interest does not lie in writing to FDA or Health Canada and seeking an indication for this drug because this drug is very cheap now. So there's no new profit to be made out of another indication. So a lot of times when there is money and there is a particular reason why the drug company wants to pursue an indication, that's an entirely business decision. and they will do it. They will obtain that indication. If it appears to them that another indication is going to be helpful, they will do that. Otherwise, they will let it be. And then scrappy clinicians and physicians that we try to use every tool available to us in the box. So, for example, early on, somebody might have thought, okay, antipsychotics in psychosis reduces agitation and aggression. I wonder if it works in agitation and aggression that is not driven by psychosis. So let me try that and see if that works. And so they might have tried with the patient and family's consent in 1 or 2 cases, and maybe reported that. And that gave other people the confidence to try it in larger and larger and larger samples until it becomes clear to the community that these drugs work in a certain way. However, because these drugs might be old or they may not be profitable, they will forever stay in this unofficial off-label designation, even though they might be very, very effective. I hope I've tried to answer this. I don't know if I made it too complicated.
Yeah, well, it sounds like you're kind of getting at this idea that just because something is called off-label doesn't mean that it's like shouldn't be taken, that in fact there's different reasons what makes something become kind of on-label. So with antipsychotics in our population, it's been approved by the FDA for kids with irritability who are autistic. But does that mean that it doesn't work for people who are autistic who are older than kids who are irritable? There may be a lot of people who've shown that it does work for that, but no one went through the process of getting the FDA or Health Canada to approve it.
Exactly. Yeah, and also there may be 1 or 2 drugs that might be officially approved. But then there are other drugs which may not have received official approval, right? So for example, risperidone is the most commonly used drug in children with autism for behavioral difficulties, for example. But then antipsychotics come in a whole range, and it's possible that somebody did not do well on risperidone, which is on label, but actually does better on a similar molecule, which is off label. Right. And so there are those possibilities that remain. Essentially, what you understand is that this may work, and then you figure out which one works best in your situation.
Yeah, sounds like you're talking about medication trials, right? Like we're trying the medication to see if it works. And sometimes we're going to start with one, but if it doesn't work, we may go to another, which is, I think, also what Aideen was talking about in her experience with her son around taking several years to kind of figure out what made the most sense and work best for them. All right, the other thing you talked about there is you talked about side effects and the sort of the issue of side effects with medication. So first, you know a lot about antipsychotics. What are the side effects? And then I'm going to ask you questions about how we sort of address them.
Yeah, great question. Again, this is my bread and butter. But before we go to side effects, let me address something related to the effects, because generally speaking, a lot of the evidence of efficacy of antipsychotics comes from schizophrenia related disorders. Some of it, of course, comes from developmental disabilities as well. But the body of research in psychosis is much larger. And if you look at that body of literature, it appears that most antipsychotics are largely similar in their efficacy. So they don't differ very much in terms of how well they work. There are differences, but they are not massive differences. And so that's important to know, because that is usually not the basis of how we select antipsychotics in most cases. So we are not worried about whether this antipsychotic will work. We are more worried about what are the side effects of these antipsychotics. So when you look at side effects, there's a wider variation in how antipsychotics behave. So you can take all the antipsychotics that we have and arrange them in order of their weight gain, for example, of their sedation causing potential, of their stiffness or tremor causing potential. And some of these variables then decide what might be better for a given individual, given their particular circumstances and their likelihood to manage side effects. And so some of the side effects, some of the most common side effects are sedation. Sometimes people can feel stiff or tremulous because antipsychotics can alter how their muscles and nerves work. Weight gain and related side effects are one of the most common side effects. So that includes weight gain, risk for diabetes, changes in cholesterol levels, They can sometimes affect the heart, sometimes affect the liver, and very rarely the kidney. Sometimes immediately after taking a dose, somebody can have blood pressure fluctuations, and that can cause fainting. So the list of potential side effects of antipsychotics is quite long. However, if you look at the most common ones, or the ones that people find most troubling, sedation and weight gain and this movement-related disorders seem to be the most common. Also, some people, often the brighter ones and the ones who are higher functioning, might report a lack of engagement or feeling numb or dulled somehow, which is a direct effect of them working on the brain neurotransmitters to stabilize things. And that stability can sometimes feel as numbing.
Yeah, I mean, and there's a language thing there, and I think what you're trying to get at there is that we don't always know how people are feeling in terms of their side effects. And some people are going to have an easier time communicating, like with words and talking to you, this is what I'm experiencing, I'm noticing this. And other people might be taking these medications, and it's harder for them themselves to describe by speaking what it is they're experiencing. So they might be able to type what they're experiencing, or they might not have a way of using words at all to say what they're experiencing. And we just have to kind of watch and make our best guess to try to understand what it feels like for them to be on those medications, right?
Yes, and that's Edine spoke about it a bit, and I empathize with her. It is very much a trial and error. It's very difficult to predict what will work or sit right with a given individual. And yes, sorry to use this colloquial term, but you have to sort of muddle through the process, because unfortunately, our science has not evolved to an extent where we could say clearly this drug will work for you. And so you try a bunch out, and hopefully the first one works, but if not, the second one works. Yeah.
So again, this idea of trials, and maybe how we all have to be thinking about, which side effects would be most likely, which ones would be most difficult for us to experience, right?
Yes.
And so which one do we start with? There's a nice question that came into the chat, really looking at, if you are going to try a medication, so you're trying an antipsychotic, big step, right? To agree to take an antipsychotic. How long do you try it for before you say this is not working?
That's a question. So again, typically a few weeks. So in psychosis, for example, the range provided is 4 to 12 weeks, and we call 6 weeks as the average minimum before we decide that this is not working. Again, in your particular circumstance, that may be a bit more protracted. So again, I thanks to Yona, I've started working with individuals with developmental disorders a bit in my clinic, in the metabolic clinic, and I'm seeing firsthand how sometimes you have to slow down titrations compared to the neurotypical individual because of sometimes higher sensitivity to potential side effects. And so what you want to be able to do is to very slowly, carefully build up to a dose that brings you some effect and manageable side effects. And finding that out can take a few weeks. So I would give myself, as a clinician, at least 12 weeks, so 3 months, and 3 to 6 months before deciding that, okay, this may not be working as well as we would like, and then moving on to the next one. Of course, the decision can be made sooner if anything completely unacceptable or intolerable happens, but that's usually the time frame. Switching before that may not be best, because then you don't know really whether it's sort of teething trouble in that the individual is still getting used to the drug, and whether the drug is working or not.
It's a big investment if then you discover that actually it's not the right medication, right? So I wonder if there's like things that you do when you're prescribing and you're kind of aware that there might be some side effects, on how to help people kind of measure those side effects to know what to look for. So
yes,
what do you do?
Exactly. So this is a very involved discussion, like you're pointing out, Yona, and sometimes what happens is that I don't want to speak for all clinicians, but sometimes it might happen that the clinician is anxious to get that drug to you because they feel rightly that this drug might help. And so in their effort to get it to you, the discussion on the side effects may not be as detailed or involved because it can sometimes scare people to hear about all these side effects all at once, which sound so strange and severe. And so what might happen is that you might have a brief discussion and then you wait and watch. And as new side effects develop, you discuss them more. Some of the strategies that can be used is to provide written material or follow-up conversations on side effects after an initial conversation of what the most common side effects are. One of the strategies that we use is to start really slow, or start really low and go really slow. And so you extend the timeline of getting the body onto this drug. So you're essentially waiting for the body to very easily develop tolerance and sort of getting used to that new substance in the body and the brain, and then gradually moving on from there. So those two strategies, information helps, strategies to manage this helps. I think also another thing that can help is to tell patients and families that most of these are addressable. So if something comes up, there are options available. And again, Nadine referred to that. There are medications to manage side effects. Would I like to live in a world where antipsychotics have no side effects? Absolutely. And hopefully we'll reach that world someday. But until then, we have these drugs. And again, for all the discussion about side effects, we should, I think, appreciate that antipsychotics, when they work, are very effective. They're overall, they are good drugs that can bring a lot of improvement in symptoms when used correctly. But the side effects have to be mindfully managed. And some of these discuss starting low, going slow, going an ongoing discussion about side effects and proactively managing side effects as and when they appear. I think a combination of these strategies can be helpful.
Okay, so a few things I'll pick on from there. So I'm going to remember start low, go slow. And we can share some resources and stuff around some of these medications for this population sort of after the webinar today. We'll send that stuff out to people. But you talked about if they're being used for the right, and I think that's a one just sort of caveat that when I talked about the 40% of people using the medications, you know, ideally we want to always think through why we're using this medication and how it's going to work and how we're monitoring side effects. But sometimes the decisions might be made quickly or with people who don't have as much experience understanding people who have developmental disabilities. So we do want to make sure that we know why we're taking the medication and what it's supposed to help. And I think if we're uncertain about that, it's really important for us to have those conversations and think that through, right? Because we are sort of, you know, agreeing to take a medication that really may have some positive effects, but like you say, also has some side effects. I wonder if we can look at some of those side effects a bit more specifically. So you've answered some questions that are coming up around, you know, how long we should try something for and that sort of thing. Someone wants to know, first of all, if you start a side effect, and this is maybe why you keep someone on medication for a while, is the side effect going to stay exactly the same as you continue with the medication? The side effects, can they get worse? And can they also get better?
Yes, all of the above, exactly. That's exactly the reason, because our bodies are strange and wonderful things. And so once you add something new to it, it's difficult to, from a single point assessment, it's difficult to say whether things will get better or worse. And we know, for example, certain side effects will get better with time. They tend to get better with time. So sedation is an example. Anytime you start a new antipsychotic, one can feel quite sedated, but over time that tends to become better. Movement disorders tend to stay stable, give at a particular dose. And then if the dose goes up, they become worse. If the dose comes down, they become less. Weight gain, for example, happens early and quickly, and then it tends to plateau out. And so if you're trying to manage that, you want to be doing that sooner than later. So yes, these side effects can change over time, and therefore it's important to give it time to figure out whether this will work or not. But again, everybody has a different tolerance for change or pain or discomfort. And so if at any point in time that threshold is breached, then immediately, of course, you want to undo that quickly and take steps to do something else instead of waiting and watching at that point.
Right. So it sounds like that relationship again with the provider is really important, and kind of understanding what medications are doing and also what stuff to look for and how to be able to communicate that when you notice it. You know, you talked about how some side effects get easier over time, some stay the same, and then some get worse. And you talked about how weight gain, which is one of the side effects, and you mentioned a couple of other things, we call them metabolic things, they can start pretty quickly actually. And that's, I know, something that you're also researching
Yes.
now. So why don't we talk a bit more about the weight gain? I'm already seeing a few questions from people around, you know, the idea of their family member going on this medication, you know, dealing with weight gain and not even necessarily like eating that much more.
Yes.
So like, why is that happening? And what do we do about that?
Yeah, so this is precisely the focus of my research, Yona. Thank you for asking me about it. So we don't understand it as well as we would like to. However, what we do understand is that antipsychotics bring about a large change in how hormones work in our body, especially the ones that regulate feeding and satiety. So some two key hormones there are insulin and leptin. And so what can happen when somebody gets started on antipsychotics, and this can happen very quickly with the first few doses, is that our ability to feel full can change, and our ability to understand our food preferences can change. So there are certain antipsychotics which can, many antipsychotics can make somebody feel intensely hungry, and hungry for all the things that we typically consider as not the greatest food. So high sweet, high fat, fried foods, and so on. So that happens, that tends to happen in the short term. What it also does, antipsychotics can do, is that they can raise the insulin levels, and raised insulin levels over time can add weight to the body, even in the apparent absence of increased eating. And so you might find that there are people who parents, or they themselves will come and say, I can't stop eating, just make me stop. And there are other people who will come and say, well, I don't change, I haven't changed anything. I'm walking the same, I'm eating largely the same, but my weight is going up. And so these things can happen with antipsychotics.
Okay, so it sounds like it is a risk or something to consider, is sort of, first of all, what, like, you know, it may be that your appetite actually changes, and it may be that even if it's not changing, there still might be weight gain. And why is weight gain a problem? Like, what do people talk about as being concerning to them if they're having weight gain, or what do you get concerned about around weight gain?
Those are two very related but also separate questions. Weight gain is now, at least in the psychosis world, the number one reason why people go off their antipsychotics. And I think listeners here will appreciate that not only are you dealing with the fact that there is a diagnosis and that there's a new drug added to the system, there's also this weight gain which can, depending on how bad it is, alter the perception of yourself. And so we have had people who are ex-athletes or extremely active people suddenly put on 5, 10, 15, 20 pounds, sometimes as much as double their body weight, you know. And think of what it does to the sense of self. And it becomes very difficult to then imagine that they will continue on this antipsychotic because this has essentially changed who they are. And that can become very difficult. So that's sort of the weight and the perception part of it. But over time, biologically speaking, weight gain is not healthy. And so it can increase the risk for diabetes, for heart disease, and stroke, and things like that. In people who have psychosis, their life expectancy tends to be lower than normal population. And research has shown that some of that could be because of higher risk for heart and brain disease that may happen because of the higher weight and less access to health. So it is worrying. I run the metabolic clinic, so we have young people there, so people who are 20 and 30 and so on, standing on the verge of diabetes or already developing diabetes, which is heartbreaking to see. And they know, and we know, that they need those medications to stay healthy mentally, but we also know that these side effects are becoming a problem left untreated. The good news, of course, is that there are treatments available, but untreated, these can cause problems. and that can reduce the quality of life, the overall lifespan, and so on.
So it sounds like, first of all, that awareness of some of these things that can happen. So far, you're not selling these drugs that well, I have to tell you. So it is important. At some point, we'll also try to highlight how sometimes these medications can be very beneficial for people. But you also talked about this idea that there are things we can do about these side effects. So I think for people listening or who've experienced, weight gain or watched their family member go through weight gain, what are the things that you can do about it? Because that is, like you say, it's something that makes people actually stop taking the medications, and maybe the medications are helping. So what do we do for weight gain?
Yes. So let's go back 1 second. I want to be absolutely clear that I'm not against antipsychotics when used properly. In fact, I prescribe antipsychotics every day in my clinical practice. They are essential drugs. And again, they do. So if let's say, if we take all the drugs available to us in the medical field and arrange them by their effectiveness, antipsychotics will be like the top 10 or 15. That's how good they are. They are more effective than your cholesterol lowering drugs. They are more effective than aspirin. They're almost as effective as antibiotics. So there's a term which is used, number needed to treat, which means how many people must you give a drug to see one different outcome or one person to feel better. Antipsychotics, the number is 2 or 3, which is amazing. We are happy with drugs whose numbers are 100. So if you give it to 100 people, one person becomes better. We have drugs that we use like that in our field. Antipsychotics are very, very, very effective. However, I don't think we should stop there. That's the entire point. Yes, we have an effective drug, but we also have, with that effectiveness, a lot of side effects. And I don't think we should give up. We should do all we can to reduce the side effect burden so that we are left with this amazing ability, but not all the other impact they cause. And so that's the spirit of this discussion. And so when it comes to weight, recognizing it early and treating it early, I think makes a lot of difference. Unfortunately, again, this is a rapidly developing field and not a lot of people have focused on it historically. We, as a field, tend to not treat it proactively, and it gets ignored until it becomes a bigger problem than it could have been. And so starting treatment early. So what can you do? Well, diet and exercise are always frontline. So make sure you're eating healthy. A healthy, nutritious diet. Canada Food Guide is a reasonable source to go off of, and then you can make modifications depending on your culture, preferences, and access. And then exercise, the generally recommended suggestion is 30 minutes of moderate intensity, at least 5 times a week. However, what happens is that antipsychotics can sometimes cause these intense changes that diet and exercise cannot handle by themselves. And so in the psychosis field, again, there is evidence that a drug called metformin can help. And so metformin is a very, very old drug. It's been around for 80 years. It's the most commonly used anti-diabetes medication. And in the normal population, normal meaning the diabetic population, which is not mentally ill, it really does not, or have mental illness, it does not cause weight loss. So it is not your Ozempic where everybody gets weight loss. It's not like that. Metformin is actually an anti-diabetes drug, which in people who are on antipsychotics, when you use them, again, off-label, because we don't have an indication yet, it can cause weight loss. And some of our work has shown that in psychosis. It can cause 5% weight loss in about half the people. And that can be very helpful because it can start a virtuous cycle by which people start losing weight, and it can effectively reduce their risk of developing diabetes or prediabetes.
So it sounds like that there's the things we can do around what we like with our bodies, so what we eat, exercise, that sort of thing, but we can also look at a medication that doesn't have people lose weight when they take it with diabetes necessarily, but that this population on this medication actually does often lose weight, which helps. Yes. So I know, and I'm involved in the study, so I do know about it, but what about, metformin for people with developmental disabilities taking antipsychotics? If it works for people who have psychosis and who are taking antipsychotics, so it sounds like that's what you would prescribe to someone taking an antipsychotic who is experiencing weight gain.
Yes. And so even when you talk about off-label drugs, you want to have evidence to be able to say that this drug will work. And so right now, evidence exists in psychosis. There's only one study, which has, again, it's a Toronto-based study. It was a very nice study where they showed that when given to children with autism, this was Holland Bloorview, they showed that when metformin was given to children who are on antipsychotics, it led to weight loss, and it was effective. The reason the two of us got interested, and you got me interested in this field, Yona, is that adults with developmental challenges, there's very little evidence out there. And so when adults with developmental disabilities face these challenges, there's nothing to go by. There's no evidence. So we know that in general, metformin works with antipsychotics, but we can't say that it works with those with intellectual or developmental disabilities because there's nothing in terms of guidance. And so what we did a few years ago now, just as the pandemic was unfolding, was to start looking at adults with developmental disabilities, have them come to our clinic and offer them these treatments that we have. And what we found, surprised us because it worked twice as well in adults with developmental challenges than it would do in people with psychosis. We were expecting at best a similar response. But then we were very surprised as to why this is happening. And we don't really know why that could be happening. It is possible that biologically individuals with developmental challenges are different, and so they are more amenable to metformin effects. It's possible that the way antipsychotics are prescribed, it's different. And so anyway, the happy story here is that metformin worked very well. And so now we wrote to the federal government, CIHR, and said we want to really study it in this population properly so that we can publish some data showing that this is effective or not, which can then guide clinicians in prescribing it. Because as of now, most psychiatrists and most GPs will likely not feel confident about prescribing metformin for antipsychotic-induced weight gain and those with developmental challenges because of how little evidence there is. And we want to change that. We want to develop good quality evidence and show whether it works or not.
Right. So I guess for people who are interested in that research or learning more about that, we can also share information with people about that piece. There's a lot of questions in here. So I think one question has to do with, you talked before about side effects, but what happens if you have side effects and you just stop? Like how do you stop with side effects of antipsychotic medications? Is there any problem to just stopping? Because that seems like if you want to stop the side effects now, just stop the medication, right?
Yes, so it goes to the heart of why the medication was started in the first place. And so if you stop something abruptly, you run the risk of that symptom coming back. And then there's also our bodies, the way our bodies get used to something, you want them to gradually get taken out of that system, and you don't want to do anything abruptly. So if you do want to stop an antipsychotic, speaking to your prescriber and doing it mindfully and gradually would be the way to go. It also then starts a discussion of whether it can be replaced with something else which has a slightly different side effect profile that perhaps might be more amenable. Stopping a medication abruptly in a large majority of cases is not advised. If you do have severe side effects, please take yourself or your loved one to the emergency department and they can treat that if needed. Abruptly stopping the medication may not be the best idea without medical supervision.
Right. So it's kind of, again, like thinking about what that drug is doing in the body, which is something that we may not understand ourselves, but having that kind of facilitated or supported approach to making the decision, because you might bring another drug in, or you might just take the drug off a bit more slowly, or there might be something you can do also for a side effect that hasn't been tried. So those conversations really matter.
Yes.
Okay. So still a lot of great questions that people have been bringing. I'm going to answer one question that came up, which was just wondering about this issue around sensitivity to medications. Because there's been questions from people, if someone is autistic, if someone has an intellectual disability, you talked about start low, go slow. And I think one reason to do that isn't just because it's harder sometimes to pick up on those side effects, but it's because we do know that this population can be more sensitive to things. And I would add to that, not only more sensitive, but may not be as well positioned to describe that sensitivity, right? So it's almost like we have to be really good at figuring out how to be detectives to pick up what that sensitivity is if the person can't really explain it very carefully themselves. So just to be observing things as well as having people report things on their own, and really taking the time, I think, to watch what those side effects might be, because there can be a greater sensitivity.
Absolutely.
Yeah. So I don't know if you had any questions for me. I know there's a big question. We talked a little bit about, you really, I think, did give us an important reminder with all the talk about side effects, because that's a big focus of your work, not to forget that the interesting evidence, right, or importance of how these medications do work for many people. I don't know if you have any like interesting kind of success stories around the medications, both either antipsychotics in themselves or antipsychotics and maybe something to support the side effects that you think went well, without giving out too much sort of, confidential information about patients, but helping us to appreciate how sometimes medications can work.
Absolutely. So let me share 2 or 3 of my favorite ones. So I'm very fortunate to work in the Clozapine clinic at CAMH as well. And so
what's Clozapine?
Clozapine is
Why does it have its
an
own clinic?
antipsychotic. Clozapine is an antipsychotic that is reserved in a way for the most difficult to treat individuals. So in psychosis, for example, a lot of my work is in psychosis, so I keep defaulting to those examples, and forgive me. But so let's say somebody developed psychosis. They tried one antipsychotic, it didn't help them. They tried another antipsychotic, and it still didn't help them. They might then be put on clozapine. So it's the treatment for treatment-resistant psychotic symptoms. And so you can be sure that somebody who's been started on clozapine has had a difficult go at the illness and treatment. And so they represent some of the most severely ill individuals at a certain point in time when clozapine was started. However, speaking to how wonderful antipsychotics can be, they can be life-changing. So in the Clozapine clinic, which focuses on individuals on clozapine, I have scientists who run startups, I have teachers, I have physicians, people who live full, wholesome lives with families. I have entrepreneurs. And you cannot pick them out. You cannot tell if you met them in a party or socially, you won't be able to say that they have mental health challenges or that they are on a drug like clozapine, which, by the way, is the antipsychotic which has the maximum number and intensity of side effects. So those stories are, for me, some of the best success stories, and I treasure them because it shows that a diagnosis of a severe mental illness need not be the end of the story. Depending on several factors, the end result can actually be quite hopeful, and people can live full, wholesome, successful lives. So that's sort of how good antipsychotics can be in the right context and the right person. My favorite weight loss story or this management of side effects story is related to pandemic. And so we were struggling to keep our clinic going during the pandemic because, again, weight management and all of that is very in-person work, and it was difficult to do that. But we had these 2 individuals, one with a developmental disability and another with depression, who used this calm provided by the pandemic to really go at it when it comes to physical activity, and then taking their metformin and all their medications regularly. And so what happened is that these individuals lost about 30 kilos each. So that's 66 pounds, 65, 66 pounds each. And they have since maintained that weight loss. And then the very interesting thing is that as they lost weight, the person with depression, their brain actually started working. They felt they were sharper, and so they had given up crocheting as a hobby. And then after the weight loss, and all of these changes, they started crocheting again because they felt that they could focus better. And we know from literature that weight gain can sort of slow the mind a bit, and weight loss can conversely make it better. That has not been shown earlier, and to see that happening in that person was very, very interesting. And so we have had people who were worried about side effects, and we were able to manage those side effects so that when they got on antipsychotics, they were essentially the same weight. And so that weight gain related side effect didn't happen in individuals. So those are some of the success stories I would like to share. And yeah, it's very interesting and gratifying work because you get to help and see all of these wonderful things happen.
Sounds like you're making me think about the idea that really it's a journey people are going through, right? And we talk about that a lot when we think about people's recovery journeys around mental illness. There's something very difficult that's going on that makes people turn to medications as one way to kind of treat or support what's happening. It's one of many things that we can do. So there's other parts of intervention we want to include. But that, you know, it's not an easy fix that gets resolved very quickly necessarily, but in that relationship, right, and making those decisions carefully and as a team, we can see some really positive outcomes over time.
Absolutely.
I don't know if you can also see the questions that are coming up, Mahavir. There's a lot of questions and we don't have time to answer all of them. You might notice I'm not asking specific questions that seem like they're about a specific medication and a specific condition with a specific person. I think those are a bit trickier. But I don't know if you have any kind of final words.
Yes, I want to say a couple of things. One is that I think our field, and so the more specific you become, so psychosis, there is some data when you talk about psychosis in the context of developmental challenges, the amount of data becomes small. And then you talk about, so every step you take, the amount of information you have to go on is rather low. And in my role as physician, while I operate in this lack of information, I don't like it. And I would like to do all I can to change it. I want data to be available. I want experiences to become models for others so that, you know, all the experience that we have collectively in the community help other people going forward. And that is the spirit in which we run the clinic and the research study. We try to publish all we can so that we add to this evidence base. And so I would like to highlight that research is a very, very important part of clinical work. And we should support research in all our roles as clinicians, of course, as researchers, of course, but also as consumers. Healthcare consumers, I think, should be encouraged to participate in research because that in turn helps better treatment going forward. And that happens much better in, for example, areas like cancer and diabetes and hypertension. I think with mental health for a variety of reasons, and I think all of us need to do a bit better.
Thank you for that. And I want to say thank you as someone who, you know, has worked in this field for a really long time and, you know, has a family member with a developmental disability, that I really appreciate being able to reach out to someone who's outside of our field originally, right? But is studying something like medications and says, well, hey, maybe there are ways to include our population that's often excluded from research to try to build that evidence base up so that we can actually say with more certainty when we make prescriptions with this population that we know what works or we know how to help with side effects, as opposed to we think it helps because we've read a lot of studies that show with some people it helps, but we haven't actually done the research in the same way we do research with other people. So thank you for figuring out ways to include us in research. And if people want to learn more about your work, we will share that information. There's more questions that are awesome that we are up to the end of the hour. We can't answer them all. We'll try to take a look at them in case in our summary we can give a few more points about some of these medications and some of these diagnoses. And also if you have ideas about other things, if you like this kind of chatter we've been doing, just an informal conversation with psychiatrists, let us know if there's other things you want us to cover. We can see if we can do that in later webinars. So thank you, Mahavir, for chatting and having a hot cocoa with me today in your cable knit sweater by our warm fire. I hope people get to hang out by warm fires over the next month as it gets cooler. And thank you for joining and learning with us today.
Thank you for having me.